Good morning, all. And I'm happy that there is a split of all radiology, pulmonary, and cardiology in this audience. The topic of the averting premature death from heart disease by early detection and getting the valvular disease, and try to show some data. First, where we are and what we can do to, does it matter if we can detect the disease early? No financial disclosure. Basically, the valvular heart disease, there are 4 valves: aortic, mitral, tricuspid. Pulmonary is more for a congenital. So we talk about the 3 valves. What has happened is, largely, most valve abnormalities are detected late, as there is no prevention or treatment to halt the progress of the disease. So they are usually patient present at the final stage. And traditionally, these have been treated by cardiac surgery. So that's what has been shown to improve life, mortality, survival, and the symptoms. But until last 10 to 12 years, this field has changed with the introduction of the transcatheter options and treatment, which can be less invasive and perhaps safer, which have been shown in various studies. The 4 valves, the aortic, pulmonic, and tricuspid, which I have put it here, particularly from transcatheter point of view, we have a now approved by FDA. Only one has not been approved, is still in trial, is the mitral. Although the mitral, one type, which is the clip, basically decreasing the regurgitation, which is called TEER. Transcatheter as repair has been approved, but the true replacement, transcatheter replacement of the mitral valve is under investigation still. But other valves can be done safely. So just to say, I think it may not be, play. So how simple it is. You puncture from the groin, patient is still a little sedation, you bring the valve in, pace the ventricle at 180, inflate 10, 20 seconds, and deflate, take your balloon out, valve is there, you're done. Actual time, maybe 5 minutes, all the preparation another 1 hour. But these are what has happened, very safer or safe to the patient, particularly elderly patients where biggest region is their lung disease or CVA, the intubation, every surgical procedure required. Transcatheter procedure, majority of them we do without intubation. So this really has changed the field taking care of these patients. And this is very interesting slide. It's a little complex, but I'll just try to make it a point. This line is the tower in United States from 2012. And this is your surgical valve replacement for aortic stenosis. You see there, first 4 to 5 years, when the tower was introduced, which is the replacing the aortic valve by the transcatheter, what has happened to the surgical valve? Nothing. So what happened here? What happened to these AS patients? Where were they? They were right here. They were not being treated. Many of them were left to making inoperable or palliative, left to die. What transcatheter option has done in these patients who are high risk for surgery, when most common reason for high risk is elderly age, 85, 90, 95, but they're functional, and COPD. Those are the 2 most important reason to decline surgery. And just to say that how the transcatheter option has really changed treatment of these patients, there was no option. And good thing is, if you compare with surgery, which is the traditional gold standard, that transcatheter valve and multiple strategies of the risk, low risk, high risk, intermediate risk, all of them has come as good as surgery. This is the 10-year data, or even slightly better in many of the studies, and the valve deterioration is equal. So now we have the transcatheter option, safer to the patient, it works as good as surgery, and we know that these patients remain less in the ICU and can be extended to more patients. So whole paradigm of treating and diagnosing the disease will change. Now, just like has been showed quite a bit, various risk factors for the coronary artery disease, we have the same for the valvular heart disease. There are stages A, B, C, D. A is at risk patient at the risk of development. Valvular heart disease, elderly, calcium, rheumatic heart disease, and so. Then progressive is B, the patient with progressive disease, mild to moderate severity, but asymptomatic. Then the third group is asymptomatic, but now they are severe. And there we actually divide in C1 and C2 based on their chamber dysfunction, whether it's a mitral or aortic or tricuspid, so in the chamber dysfunction. And then lastly is the symptomatic severe patients who have developed symptoms as a result of valvular heart disease. What we have done so far in the past, that surgical procedure is done in class D. But what if the thing which I showed you, that we go to the asymptomatic but severe? Why? Because wait and watch, I'll show you some data. That itself has a problem once you become severe. Or we can go even one step further, and that is what if we go to even moderate disease, asymptomatic. And this is what I would say the transcatheter options will provide. So what is the logic behind to go early in this disease process of the valvular heart disease? So this is kind of a nice description in a graphic form, that before going to the top, if you can intervene early, clearly that your gain and improvement and the overall survival and more importantly, durable benefit of the patient will happen more. And this actually, we have shown, this we learned almost half a century ago. And this is actually even true now. The patient with aortic stenosis, they continue at one point at mid-age, once symptoms or any of the symptoms, angina, syncope, or heart failure develop, rapidly decline. The mortality 50% in 1 year, 80% in 2 years. Even at present, about 10 years ago, we did the trial, Tower versus medical management, and mortality was 50% in 1 year in the medical management group and 80% in 2 years. So whole question is, why don't we go early in this scheme? One of the reasons which I mentioned earlier, that many of these patients don't go, the type of valve disease when happens, whether it's aortic, mitral, almost 20 to 50% do not go for surgery despite a class 1 indication. And as I said, these valve disease is predominantly, particularly in America and other places, not the rheumatic, it's all the disease of the elderly, and many of them don't get treated. But at the same time, once you have a severe stenosis, this is a classical example from the aortic stenosis, that patient has, the trials have done, that you have a severe aortic stenosis, and now is the C. They are in C group, asymptomatic, severe. Should you wait and watch, or should you replace it? And the answer is replace it, because wait and watch is creating a trouble. Every trial has shown the surgery will be better. Whether it will be with a transcatheter, we'll know the trial will be presented next month in the TCT, which is early tower. And this goes back to the point that the higher the stage of the patient, because you start developing the ventricular dysfunction and irreversible damage, even if you replace, by the time you get to the stage 3 and 4, there's still some fibrosis. And of course, all the data of the non-invasive MRI and showed that that damage persists. Whether it's a mitral or aortic, and patients continue to have some death, although improvement. And this is actually have shown that not every patient, you have severe aortic stenosis, one person is in the stage 1 group, where there is no myocardial damage, other one is in the stage 4 group, there is a myocardial damage. Survival is dependent on what the myocardial damage is, irrespective. We improve the outflow. We replace the valve by the transcatheter option, and not everybody gets improvement, as you can see, and so. So therefore, the burden of valvular heart disease is a population-based study, just to emphasize who develops valvular heart disease, and that is what our goal is. There are many studies have shown that whether you go with the all valve disease, the mitral or aortic, it's a disease of elderly. Some factors comes in. They have high cholesterol, inflammation and all, but prevention for those using the drugs, statins, nothing has really made any difference, but it is the disease of age. And more importantly, it's very interesting. Women are less diagnosed than men despite higher disease. So you take aortic stenosis at 90 years of age, there will be more women than men. At 50 years, in a coronary artery disease, there are way more men than women. But aortic or mitral, all these diseases more in women than men. One, likely because it's the older age. Second, women live longer than men. So chances to having a valvular heart disease is much higher. And therefore, this is very important public health problem. But question is what to do. And this is where the whole things happen in the sense that you have to follow these patients with the various criteria, and just emphasizing once again that increasing age giving rise to increasing regurgitation, stenosis, or so. So just to emphasize on the part of the aortic or mitral disease process. Now, you say, does it matter? Yeah, even you have mild, moderate, or severe valve disease, mortality is higher. So we understood we need to diagnose early and intervene, whether intervene by surgery or by transcatheter, but key is the diagnosis first. So this is the one important point. That there, and then what we can do. Same, emphasizing another, that was the earlier publication. This is a more recent publication, emphasizing all three valve disease: calcific aortic, degenerative mitral, tricuspid regurgitation, male in blue and female in red. And you see more women than men, and the increasing incidence of disease process with increasing age as shown below. So therefore, the point basically is that we need to diagnose at early stage all the valve. So there is a third valve, which is in the community is less spoken, but now it is really emerging, which is the last one is the tricuspid valve, which is actually maybe more common than any of these two valve disease. But we call it a forgotten valve. But now, since we have the treatment option, we're more and more being spoken about. So this basically puts it together some concluding slides that what we can do about it, the gaps which we have, and more importantly, solution. The screening the patient, and how would you start the whole process and follow up of these patients before getting to the more advanced treatment. And I would say this will start with simple symptoms and examination. I know the stethoscope is almost like, for many people, obsolete, don't use it, but that's probably the first thing. Patient comes to the office, you start seeing murmur. Everyone has a murmur. So when our fellows present the cases, nobody auscultate the patient. I say murmur was detected on echocardiography because nobody listened to the heart. But that could be the just first screening, because how can you do at the mass level? But once you found that the murmur, then you go to the next level. And that's where you go into as a primary care or as a general office, then you go to the next test, and that is echocardiography. That's kind of the gold standard to determine how bad, what is the situation of the valve disease. And then, of course, you go to the more expert cardiologists with expertise in valvular heart disease. There are separate clinics, which we have also. And of course, there's more complex. You go to the valve center of excellence and trying to follow up those patients. Not every patient which comes referred to us goes for the procedure, because in cases if they are in patients if they're a moderate level, we say come back for follow-up and so. So basically, this will be I would say the scheme of early detection, getting to the treatment after the full show. And then, of course, is special ward clinic. And I'll just sum it up. They basically that in absence of symptoms, there might be a benefit of surgical or transcatheter intervention to prevent deleterious long-term effect on the left ventricle. So even if, as I mentioned, that sometimes you can change the valve, but patient may still have bad outcome. These are issue because most of the guidelines is still class 1 for the symptoms, but guidelines are changing, and the patient need to have more close follow-up to detect the severity or the symptoms and intervene. And that overall in the population point of view will make a big difference. Thank you very much.